So, so I guess that, I think probably the most important thing that I think would be helpful is I want to kind of start by dispelling a myth, and maybe I'll just throw this myth out to you right away, Carlee, to see about what your thought is. Have you ever had other doctors kind of throw out like, oh, well, MiSight's FDA approved, but there's these other options that work just as well. Like, how do you address that with patients, and how do you address the issue of like an FDA approval and why FDA approval is important compared to like something that sort of gets us close, or maybe can do something that's similar but has never really been studied in an FDA manner?
There's kind of two things that I think about when I'm talking to patients regarding and other doctors regarding that, the FDA approval. Number one is I feel like parents value that a lot more than we may think they do. They value that it's been through such a rigorous process of studies, and that it's been studied on kids in that manner. With a lot of the other lenses that are not FDA approved for kids, sure, they're safe and they've been studied in adults, but I think parents really understand that, adults are not the same as kids. And so having that FDA approval and backing is really important to them. So I think that's important to remember for other practitioners. And then secondly, I've worked now with, I was doing myopia management before MiSight was available. So I've used those other lenses. And now I've been able to compare for the last year patients that are in the non-approved lenses versus patients that have been in MiSight for a year. And I can honestly say that the MiSight kids are happier because their vision is better. I don't have to prep them as much with these lenses are going to feel kind of funky. I just act like they're totally normal contacts. I don't need to tell them, your peripheral vision is going to be a little weird and you'll have to get used to that, which is something I did have to do with the other lenses. And then the effectiveness for all of my patients, I've maybe had to make 1 or 2 adjustments through the year for, I think I have at least 25 kiddos in the lenses, and they're staying stable. And so to me, that's most important. And that's what I really try to tell other doctors as well, is like, put it to the test and remember that, that FDA approval is good for safety, but it also is good for the effectiveness of the lens. And we shouldn't forget or discount that when we are trying to explain to patients or when we are ready to try some myopia management options.
Hello and welcome to the Chris Wolf Podcast on iCode Media. Today I had a great conversation with Dr. Carlee Young about the implementation of the MiSight lens into her practice and how she has a conversation with her patients and parents about how that lens works and the benefits of that technology for the patient. It was a really fun conversation to have. Please enjoy our conversation, and as always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us.
I think we're up on a year.
A little over a year.
And
yeah.
So I had a patient. So we've been doing the same thing as you. We've been doing myopia management in our practice for years and years, and we've been using some other types of lenses. And I had a patient that was in a different type of lens, and actually like everything had been stable. And so we didn't change her at that time. We had a conversation about it. We had a conversation with the parents. Her parents didn't want to change because they had a decent effect. But then 2 things happened. One is the manufacturer shipped, so we were direct shipping. So they shipped her a spherical version of the multifocal lens that we were using. And so she went for like, I don't know, a month, maybe 2 months, and we didn't know about it. And then she, fortunately, she didn't progress in that month or 2 months, but the parents noticed that the boxes were a little different, finally, after a couple months. So she came back in and we put her back in that other lens and she's like, it's too blurry. Like she had the exposure of, she had never worn contacts before.
Yeah.
And so she hadn't had the exposure of a spherical lens. Well, so the beauty of it is knowing what you had just said is like, I agree with you. I think the optics of the tolerability of any peripheral blur with MiSight is really good for kids. Yeah. And so in this patient, she couldn't tolerate, even though she hadn't progressed, she couldn't tolerate the blur she was used to before with that other soft multifocal. And when we put her in the MiSight, I was like, oh, great, that's fine, right? And so it was to me, that was really eye-opening that the optics were so much better, and that secondary kind of thing that we say, yeah, you're going to notice it's not that big a deal, was just a non-issue. So I thought that was pretty cool. When you think about those types of patients like that miss appointments or that have progressed, not necessarily with a contact, but like also, they've been on the screens for a long time. Maybe they missed something over COVID and now they're coming back in, their parents know. Does that how does that conversation go? And what does that look like when you're changing a patient from what they were doing before?
So that has, that's been a big deal, especially here in Texas right now is pretty much when we were starting to reopen last year after quarantine. So we had closed the offices for, I believe it was about 8 weeks that we had to be closed. And so just the way that the cycle of reminders work right now, I'm getting a lot of those patients in that decided just to not come at all during quarantine. Along with the virtual learning that's been happening for the past year, a lot of those kiddos have had progression that maybe we had said we were going to monitor or that wasn't a concern at the time. And now I find myself with every myope, I'm with their parents, I'm discussing myopia management and, really letting them know, like, this is something that we need to do because, and I try to ease parents' minds and, make sure that they know the virtual learning was a necessity. So is it the only thing that caused progression in their vision? Probably not. No. Can we do better this summer, getting outside more and updating our glasses? Absolutely. But I do try to, make sure they know, yes, I think the research is there that's going to show us that, this year of virtual learning has not been good on myopic kiddos. But I also want parents to, be realistic and not feel too guilty about it. But I do think that
it's the world we live in, and I think that
exactly.
The challenge is that I think in a lot of cases there can be this false sense of hope where like just send your kids outdoors. Like, yeah, that's great.
True.
But when I talk to parents about it, I'm like, yeah, that's wonderful. You should do that. It helps us definitely prevent or reduce the onset of myopia.
Exactly.
But like once you're in this, we can't just be like, okay, well, no more Zoom meetings. It's never going to happen. Like that's not practical because that's even after COVID, right? Even after we get beyond this. I mean, this is what we do, right? Like it's part of our world. It's built into the cake and it was coming. It just was accelerated. So I think this idea of like, because I agree with you. I think that there's people that, just think, oh, well, I'll just tell people to put kids outside. It's like, that's fine. And that's really good, but it's not practical.
That's not the only solution. I think that's what's so important is, that's one thing and that's easy to do, but these changes, especially for kiddos that did progress, those changes have happened and we don't know how to reverse it, but we can slow it down because, maybe they've started on this cycle of a half diopter change every 3 to 6 months. And we want to halt that while we have a chance. So I do think that having that discussion motivates parents a lot more. And to be able to do something that use the MiSight lens and do something that is FDA approved and well researched. I do feel like a lot of parents are more, they're kind of really keen to that information and ready to take action. And so when I would say prior to the pandemic, my conversation with parents may have taken 2 or 3 visits. It would be the annual exam, first discussion, a 3-month follow-up, second discussion. By 6 months, they're like, okay, I think I'm ready. Let's go ahead and try the contacts. Now it's annual exam that maybe hasn't happened in 2 years. We see a big change. We discuss that change and they're like, let's do it. Let's try the contacts.
Wait,
we get moving on that.
Protocol. How do you differentiate between those kids that you're going to see back, let's say at a year, versus the kids that you're going to see back at 3 months or 6 months? Like, what's your determination on whether or not you're saying like this kid's really going to be a progressor or this kid's probably not going to progress?
I think a lot of it has been learning by experience what I'm comfortable with for my patients. The more history I have with that patient, the more comfortable I will be at saying, you're good. You had a quarter change. It's been 1.5 years. We're going to stick to 1 year. If I see a new kid, an 8-year-old myope, or even of -0.5, if they are anywhere in that risky range and it's their first visit with me, I bring them back in 6 months, pretty much no matter what. And I explain, maybe, even if they're Plano and 8 years old, I explain to their parents, look, they don't need glasses today, but there are some risk factors that tell me they might need glasses sooner. And the sooner we address that when it's needed, the better. And so 6 months tends to be my go-to for those lower kiddos or a first-time visit who doesn't have a family history or other factors. And then if I have a kiddo who first time they're like a -2, both parents are -6 myopes, they have an older sister that's a myope, something like that, I'm seeing them in 3 months. And again, I think I've had a lot of parents they're totally okay with that. They would much rather be proactive in that way, especially when I explain why I want to see them more frequently.
But Dr. Young, that's okay. Is my insurance going to cover that next examination?
That is always the next question. And no, they are not going to. We have, in my office, this has worked out well for us. We have a myopia refraction exam. So it's priced like a lower level office visit. And I tell them that right up front, right when I'm telling them that they need to come in. And most parents are perfectly okay with that. They're prepared for that. And I tell them, look, this might be something that medical insurance will cover in the future, but right now, that tends to be lagging behind technology and importance in healthcare. And so we need to get them in and whether or not it's covered.
Are more accepting of that than I think most doctors think they will be. So I think the hindrance in many cases of that conversation winds up being like, oh, I don't know if I can have them back in 3 months. How do I charge for it? How do I bill for it? Like, it seems like you've solved that problem and it's not really a hard problem.
Exactly.
Yeah. And so then you, I think this is a good conversation, Carlee, because I want to dig in a little bit deeper without talking about specific fees, but with the idea of your time is worth something. And it's actually worth quite a bit when you actually analyze that data. And patients are really willing to pay for that time and that expertise because if they don't feel like they have to, I think in a lot of ways it builds in this idea that like, look, if your child doesn't need glasses or contact lenses, like I'm not going to prescribe them just because I'm making money on that thing. I'm going to see you and I'm going to take my expertise and you're going to pay for that. I think there's a lot to be said there. And I think, so how do you embrace that and how do you kind of calculate what is that kind of myopia refraction time it's going to take and allotment? Did you go through a process with that or you just sort of said, here's a number?
The way that I came about it was we had, we kind of have our standard refraction fee in the office. And so when I have a patient back for these follow-up visits, it is generally a refraction visit. We don't have a biometer at the moment to measure axial length. That is something that I'm hoping to add in, and this may change how I do things at these follow-up visits, especially. But right now it's mainly refraction. But the education and the time I spend with parents at those follow-up visits is so much more than your typical adult that may have had something where they just need their refraction changed up real quick, where there's not a lot of education. So I took our kind of baseline refraction there and then tried to kind of average out what is the time that I spend in this education with parents, and put a value to that. And then I put those two numbers together, and that's kind of how I came up with our myopia follow-up cost. And so, I've been doing that for about 2 years now, and patients, like I said, with the right education and upfront, letting them know upfront, I haven't had much pushback at all. And I think you brought up a good point that, they don't want their kid to have glasses or a change if it's not necessary. And they would much rather me be following them closely every 3 months than just say, you know what, just push the quarter prescription and I'll see you in a year. That's not good for the patient. That's not good for anybody. And I think letting parents know that and letting them understand that you want to follow their kids so closely for important reasons, I think that goes a long way.
Does everybody in your practice manage it the same way you do, or
they do not. We actually do a lot of
you or from other people?
Say that again. Sorry.
Oh, no, you got it. I was just asking, how do you manage other doctors in your practice and outside of your practice sending patients? Or are you encouraging all those doctors in your practice to do the same thing you're doing?
So I think slowly but surely. So there are 9 doctors in our office. So there's quite a bit of, inter-office referral, which is really excellent. 2 of us are pediatric specialists. So we both will see patients. We have a very similar follow-up schedule. And then we're kind of very much in tune with one another since we are we see the majority of kids in our offices. The other doctors I encourage them right now, they tend to send us the kids. So they'll see a patient they've seen for a while for an annual checkup, and they'll have a jump in prescription. And then they make that inter-office referral to me to further discuss myopia management and see if we want to do any treatment moving forward. That has kind of been how we have worked it out. I do think that the other doctors who they're not as interested in pediatrics, they're more general practitioners, but they're seeing how myopia management is growing and are becoming more comfortable with some of that follow-up protocol. So we review that, we talk as a team and go over that kind of what my thinking is with the 3-month follow-up, 6-month follow-ups. So a few of them will do follow-ups until they feel like they need a treatment, and then they'll send them to me. And others will just say, you're a myopic kid. I saw you today, but you need to see Dr. Young next time. Come back in 6 months and see her, or go see her next week because I really think you are a good candidate for MiSight. And they'll get them on my schedule. So it's a little bit right now, I think it's a little bit fluid. It just depends on each doctor's comfort level. But I do think that they really appreciate having easy access to my MiSight doctor, where they can just be like, yep, this kid's a good candidate. Go see Dr. Young. Come on over.
Do you find that, have you gotten any outside office, like other offices sending you patients?
Yes, we have. I feel like that's actually picked up more in the past year or so. Even in the past few months in 2021. And I think that probably has a lot to do with the optometry community just becoming more aware of myopia management in general and the MiSight lens and Brilliant Futures program together. So I will have doctors patients, I do think when that happens, it does tend to be more patient initiated. So they might be seen and be asking that doctor, hey, what can we do? I'm not satisfied with just glasses. And then that's when another doctor from outside of our office may say, well, I'm kind of at my limit, but I know Dr. Young does the MiSight lens, so I'm going to send you to her. And that I think has been happening more and more frequently, which is excellent.
Yeah, I think it is really good. And it's kind of this tricky situation when that happens because, on the one side, especially when you're dealing with younger kids, like, younger kids bring families and they also bring, they're going to be there for a long time in your practice. So I would assume that there's a little bit of a challenge with that referral coming to you from the original provider, or just mentally. I mean, it clearly is the best thing for the patient based on, the fact that they're not comfortable with those next stages. But the idea of like, how do you manage that so that the patient understands? I mean, this is really important. The patient understands, like, this doctor did exactly what they should do. They got to their comfort zone and then they were outside of it. So that actually should build trust with the rest of the family for that referring doctor. So I think on the one hand, like, when we get referrals and we get the same thing, we get referrals to be really delicate with those because we don't want the patient being like, well, I can do everything else here. It's like, no, actually, that doctor was really ethical and really aware of the fact that they were outside of where they wanted to be. And so they needed somebody else. That should really speak volumes to that patient. And I think as the doctor taking a referral, it's super important that we communicate that to the patient are you actively doing that? And if you are, what does that sound like when you're talking to the patient about those things?
Yeah, that's definitely something I am trying to actively do. I'm better at it sometimes than others. But I think what makes that easier is when there's open communication between me and the referring doctor. So I know, oh yes, okay, they're sending me this patient, and I know that before I walk in the door, so that I can, like you said, make it really clear to the patient, look, that doctor did absolutely everything they were supposed to up until they don't have access to this lens. This is a specialty lens, kind of a specialty treatment. So they sent you to me, which is exactly what we, want to do for our patients. And then I think that's where, especially with the MiSight lens, how it's set up, in general, letting the patient know, this is a special type of care. This isn't your typical eye exam. And that's why you need to come here for this. But for your own, maybe for the parents' exams, they should feel comfortable and stay confident in that referring doctor. I do try to, usually they come in with their glasses prescription already updated from that doctor. But if they don't, I do try to make a point of letting them know, like, here's the prescription that we're basing our treatment plan on, but that is, you should go back to your regular eye doctor and fill that there and let them continue that care that they've given you for, prior years. And then communicating. I think communicating with the other doctor themselves is really important. So I do try to send a summary back to them so they know, okay, this is what we're fitting. This is where we're at. And then, if they see them again for their annual, they can know what we've been doing in the meantime as far as the myopia management goes.
Yeah. You brought up a point about a specialty lens, and I've been talking about, I don't know if you know Aaron Warner, but Aaron and I have been talking about this back and forth a little bit, but he's very succinct in this. I mean, one of the mistakes I think that we make as clinicians is we talk about, and it's normal because we've gotten used to this with a soft contact lens. Those of us that do a lot of other specialty things like orthokeratology or scleral lenses are a little probably better because we're aware that we're using things as a therapeutic device in many cases. But the same, I think, applies in this case with the MiSight, is that you have this device, and we're not seeing how the device works in you, right? We know how the device is going to work. We already talked about the FDA data, and it's not about like, oh, do you prefer this or do you prefer that? I mean, it's really about, I mean, we want that. That's a secondary objective, but communicating to the patient that like, this is, you don't send your patient to an orthodontist to get braces to see if they work, right? They get the braces. We know they're going to be uncomfortable at times. We know you're going to have to, you're going to break something, or you're going to put wax on something so that it doesn't irritate your mouth, whatever. Like, clearly, we don't have to do that with the MiSight lens. But the point is that we should treat it more like a treatment device than a contact lens that a patient might prefer this one over that one. What do you think about that? And how's your approach to talking with patients about it?
Yeah, I absolutely agree. We should be thinking of it more in that treatment device manner so that it comes across that way to patients. And it's a fine line, I think, to balance in the education, because parents are familiar with the general soft contacts they may have been wearing for, a number of years. And that comfort can be really beneficial in helping convince them to put their kid into contacts, into MiSight lenses. But at the same time, I want them to understand that this is a specialty soft contact lens. So the way that I go about it is I tend to tell parents, I'm like, this lens, the MiSight lens we're going to try, it fits and feels on the eye like a regular typical contact, but it is specially designed with distance power and peripheral defocus to help control or slow down changes in myopia. And so I try to separate, yes, you are going to get the comfort and the usability of a lens that maybe you're more familiar with, but the technology and the optics of the lens are something completely different. And that's what really makes this lens special, and why we need to use it, and why it's the lens we need to go with. And I agree, kind of having that mindset of, this is what we're doing. This is not one of 8 lenses we're going to be trying. Right. This is the lens that's going to work, that we are, fitting to slow things down. So I try to make that balance I think it's with patients.
No, please go ahead. I interrupted.
Oh no, that was it.
Yeah, no, I think it's really important to have that communication portion, and even the mindset, right? Even the mindset of like, yeah, this is what's best. This is what's right. And unless there's something clearly off about the fit or the vision, you know that you're doing what you need to do in order to manage that patient's myopia. You said at the beginning of our conversation that you've had this now for a little over a year. Do you recall your first patient that you fit in this lens and how they're doing?
Yes, my first patient, I believe he was actually the first patient in the nation to be fit in MiSight. So that was pretty cool. We didn't know that
you're brushing your shoulder off right now.
But I am, yes. But I was just so excited because I had been to the launch back in January of 2020 now. Went to the launch in Miami pre-pandemic, and then had the lens in my office early February of 2020. And so this was a kiddo who was very active in sports, and he had actually tried regular contacts, regular daily distance-only contacts. So he had been wearing those for about a year, and then came in with a big jump in prescription. I think it was about a diopter in maybe 9 months, somewhere around there. So he was pretty motivated, and his mom was extremely motivated to see if there was something else we could do. And so I fit him in the MiSight and switched him over, and he had no trouble switching, which was really exciting at that time, because at the time I had been, coaching patients that vision was a little different. It didn't bother him at all. He just got in that lens. And then I saw him in March of this year. So I had seen him for a 6-month follow-up and he was doing fine, no changes. We continued with his current prescription. And then I saw him back a year later, which would have been, I think he ended up coming in March of this year. And he was still stable. We didn't have to make an update again. So that was just super exciting, both for him and for me, to see that success with the lens. And then, it's kind of moved from there with each patient. It's exciting to be seeing them come back now that it's been a year and a couple months, seeing patients come back for a full year. I've been following them up more frequently, but to make it to that 12-month mark is something special.
Do you, so I think that's really, we're now getting beyond this period of time where it is, where you're kind of like, we're seeing in real clinical experiences what we've seen in the FDA data. I think about the idea of, you made a point of how stable patients are.
Mm-hmm.
And, I'll probably discuss some of the other ARVO topics later, but I think the important stuff is that like, we're now getting like into this 4, 5, 6-year data in knowing not only is this lens safe to wear, but it's effective. And we're going to start being able to understand things like, okay, well, once the kid stops growing, then what do I do? How do I taper off of this? And right now we don't exactly know that, but I think we're getting close to knowing it. So I guess my point in asking that question was just thinking about like, these are questions that doctors bring up all the time, and these what ifs, and we're getting closer and closer, not just to knowing about like intuitively what we would do, but also like, okay, what do we know to do based on the evidence? And I think that's going to be really exciting to be able to tell that story as well. Not just is it safe and effective, but what do we do when we're done?
Yeah, absolutely. And that's a question.
How do we know we're done?
And that's a question a lot of parents have as well, especially when I fit an 8-year-old in MiSight contacts, then the parents are very much want to know, how long are we going to be in this lens? They see the success in it and they want to continue as long as necessary, but they're also anxious to know, what is the end point here.
What's your thought on the end point? Like in your mind, what are you looking for in general?
Yeah, so there are, and this is what I tell patients, there are multiple factors that I try to keep in mind. Number one is age. I do feel like I'm going to keep them in the MiSight lens until they're at least 16 years old, at least right now. Maybe studies will come out that will show me I don't need to do this. But right now, my method is to tell parents, we're going to be in this lens until our mid-teenage years, 16, 17, sometime in there. Even if we have great stability at ages 9, 10, 11, even if we're really stable, we still know that they're in that growing stage and I'm going to keep them in the MiSight. Once we hit that mid-late teenage years, then if they've been stable for multiple years, that's when I would consider taking them out, letting them go into a single vision, distance only type of contact. But if I see that at 14, 15, they're still progressing, I'm making even these quarter changes every 6 months, every 12 months, then I encourage parents to, we might stick with it a little bit longer. And then I try to tell them, especially with all of our technology now, all the up close work, all of the computer work, it may be a lens that we need to be in a little bit longer. And I'm upfront with them that these studies are ongoing. We're getting more information as we go, and that this plan may change. But a lot of parents, I think, are pretty comfortable with that. So it's exciting now that, we have a few years of more mainstream myopia management. We have 1 year of MiSight information, just practical use information as well. And then these studies that are helping to even further that. I think that it's going to be really exciting to kind of see what we can do and fine tune all of our approach to myopia.
When you think about like the engineer father or mother that wants to know why this is different or how this is different than a normal lens, or even maybe how it's different than another soft multifocal, what does that sound like when you have that conversation?
That conversation, I use my hands a lot. um, and I also use a lot of the images that MiSight has actually given us in our education book. I'm such a visual learner that I think that's how I find it easiest to explain to patients as well. But what I try to explain to them is that, this may look like a regular contact, but the design of the lens is the power within the lens is what really sets it apart. And I do a lot of, distance in the center. There's distance power in the center. That's going to give us our clear vision, our regular vision, our functional vision. So you don't need to worry that we're, diminishing anything. And then there's that ring of, to patients, I call it reading power. Peripheral defocus is a little, not a term that they love. They're like, defocus, what's that? So I explain it more as there's a plus power or a reading power around the edges. And because the back of our eye is round, that helps to keep the signals for growth in the peripheral vision, keeps those signals for growth inside the eye and stops that growth from happening.
I like that. I like signals for growth.
Yeah, that's like my key term is, we want to stop those signals for growth, and that happens in the peripheral vision so that we still have our functional center vision.
Well, the other thing that you brought up that I want to pick apart and have you kind of talk about a little bit is this idea that you might have to change patients, a quarter diopter, or, God forbid it's a half diopter, but the reality is that you still might get some progression. So I think that in some senses can worry a doctor, right? It's like, I talk about a lot, if you've heard me, if anybody's heard me talk, I talk about widgets a lot. And what I mean by that is like, some of us will buy a piece of equipment or a piece of treatment technology, and that widget becomes our thing. And when that widget doesn't do everything we want it to do for a patient, whatever it is, then it can be easy to be like, oh no, I failed. And then how do I approach that conversation with a patient when it didn't completely eliminate their symptoms or completely eliminate their signs? And I'm not I guess we could lump this into the category of a widget, right? But like the point is that I'm making is that like understanding your limits, understanding the evidence is I think really important, and having that conversation on the front end for parents and patients to say, look, we are trying to slow this down, but remember, slowing down is not halting. And so when a patient continues to progress, let me ask it this way. On the very beginning, how do you explain the difference between progression and halting in a way that is going to allow the patient and the parent to understand that that's the goal, that reduction in progression is the goal and not halting? And then when they do progress, even at small amounts, how do you explain that as well? What does that sound like?
Yeah, I think my conversation starts with letting parents know a lot of their first question. Let's say it's a new myope kiddo. The first thing the parents ask is, well, are they in glasses forever? Or, is there a way we can eliminate this completely? And I start by saying, no, once it's there, what's there is there. So we can't reverse it, and we can't stop it completely because they're growing. Naturally, that's what's happening, but we can slow it down. So I try to be really clear right up front that we can't reverse it, we can't halt it, but there are ways that we can keep them from changing super rapidly, with a goal in mind of keeping that risk of myopic health issues lower. And so I try to kind of start with that. And then it does take a lot of reminding to parents, especially if we go ahead and start treatment and then their kiddo is stable for 6 months. And then we see, then we need to make a quarter adjustment. I try to help them understand that is not failure. That is a success, really. What we're wanting is to not see a kid go from, a -1 to a -2 in 6 months. But if they're going from a -1 to a -1.25 in 6 months, yes, we're not stopping it completely, but we have made tremendous improvement from what would be happening if we did nothing. So I think that education is really important there, as
when
always.
you think about, I think that is important. And then I think also the other thing that I think is a limiting factor for doctors that I just want to point out is that, because I find it myself that I'm not being critical of others. I'm being critical of myself, is that I always have to resist this temptation of feeling like, okay, I'm going to do this thing, and I have to remember that this thing isn't always going to completely eliminate something else. Like in this case, it's not going to I have to make sure in my mind I'm thinking, okay, there might still be progression, right? But chances are it's going to be significantly slower, and maybe we won't. But I have to be aware of that going in, so that I don't feel like my treatment is a failure, because my reaction to those progression is going to be completely, to any potential progression, is going to be completely evident to the patient when they're sitting in my chair. And I can't have like this, oh, this failed, because one, it didn't fail. And I have to believe that. And two, my reaction to any changes can't be, oh man, geez, oh gosh, I wish this would have worked better. It's like, no, it worked exactly as it was supposed to work. It just turns out that this child was going to progress at a greater rate, and we were, and we couldn't eliminate it all, right? So I think my point of saying that is mainly for my, like, look, we treat glaucoma all the time, and congratulations, by the way, on your new scope of practice change in Texas.
Yeah, that's very exciting.
But it's awesome. But the point I was going to make with that is just that, like, we treat glaucoma all the time, and what do we, patient that is, we start by saying, look, we're going to reduce their pressure by 30%, and we're going to monitor them. And if we get to 30% pressure reduction and they have no changes, wonderful. But if they do have changes, well, we have to do other things, or we might have to, or there might be acceptable changes. If that patient is 85 or 90 years old, there might be an acceptable slow progression. That additional treatment burden is too challenging with glaucoma. So we make these decisions, and we're trained in other ways to monitor disease and to monitor our treatment of that, and not to feel like it's completely a failure if it doesn't always halt everything. And so I think I just remind myself with this type of stuff that might be the case as well, or that it is the case. Do you think that, oh, go ahead. Sorry. You were going to say something else?
One quick point that at least helps me, is I've really tried to move away from saying myopia control.
Yes.
And switching to myopia management. And, to a patient that is just a different in terms, but mentally it helps me to remember, look, the goal here, control makes it sound like we are going to just stop it where it's at and just hold on tight and keep it, we're going to keep that -2 and it's not going to budge. And that's not true. Myopia management really helps me to better express to my patients, and just for myself, that we're going to manage this. It's not going to go away. It's not going to stay right where it's at, but we're going to manage the change and the growth as the kiddos change and grow.
Yeah. Yeah. And so I think probably one of the last questions, because it does come up often, is, okay, so what about LASIK? And is LASIK different than what we're doing with this contact lens, or can my child still have LASIK after they've used this contact lens? I mean, what is your, or even more importantly, well, I don't really care how nearsighted my kid gets, because once they get to be 18, they could just have LASIK, right? Like, what's your thought about that? How do you address that or preempt that thought from a parent or a patient?
Yeah. So I try to explain to the parents and the kiddo themselves as well that, the changes that we're seeing now are growth of the back of the eye. Um, and I think that's kind of an easy thing for parents to understand because their child is growing, they're growing taller. And just like you grow tall, your eye is growing long. And so that change needs to be addressed now, and we can address it using MiSight contact lenses. And then that's where my explanation of the signals for growth and the back of the eye really is important.
Yeah.
And then I also, on top of that, like to tell parents, look, we want to keep their number as low as possible to make them a good candidate for laser surgery when they are an adult. I want to make sure they understand, LASIK surgery is not something that they can even consider until all of this growth is finished. And then once it is finished, that number we're left with needs to be low enough that the laser can correct it, which means the lower we keep it now, the better candidate they're going to be. So I try to address it in both ways, kind of what is it right now that we're doing and how is that different? And also, how is this going to help us if LASIK is something that we want for our kid or that our kid might be interested in when they are older?
Yeah, they just have a whole bunch more options, right? Like
Exactly.
it still opens up that option. It's really interesting. One of the last comments I'll make is a general observation about LASIK. But I don't know if you've noticed this in your patients, but I think LASIK is a great. But I think in the ones like patients have embraced this idea that LASIK is going to fix my eyes forever, right? And I don't know who started that myth, but it's and in fix, I think that's a very general term. But we'll just clearly it's not from a health standpoint, but even from a refractive standpoint, it's a huge myth. But they've embraced it. The other thing is that I think is really interesting about LASIK, and it's just another comment that I'd like to get your reaction to, is that I'll have patients that come in, they might be 45, 50 years old with let's say half diopter of hyperopia or half diopter myopia, and 3/4 diopter of SIL. And they're just like, oh yeah, it's fine. It's no big deal. And that exact same patient, if I was off in their refraction by the exact same amount, they would not tolerate that at all. Like there's something in the mentality or the psyche of like, I had LASIK. My vision is going to have to be really bad before I go back to glasses or contact lenses. Where like the patients who wear glasses or contact lenses, if we were off in their prescription that much, they would not be happy with us.
Yeah, that is an interesting point. It is. I think it is a lot of a mindset thing that your eyes have been fixed, and that's not always the case. I also try to, especially when I'm seeing the whole family, and I might see, a mom of my myopic kid who had LASIK, and I try to really emphasize the education in her exam that, look, yes, you don't need glasses. You're okay with your 20/20 happy vision, but the back of your eye is still a -8 or whatever it may have been. So you do need to come in. We need to do that retinal exam, and kind of make that really clear for their own eyes so that they can remember that same thing as they're thinking about their kids as well.
Yeah, that's a wonderful point. So, Carlee, I'm going to be respectful of your time. This is a ton of fun. I could go on longer, but I know I told you it would be an hour. So thanks so much for doing this. I really appreciate it.
Absolutely. It was a lot of fun for me as well.